Hypertension, or high blood pressure, is a significant global health issue that increases the risks of heart disease, stroke, kidney disease, and mortality if left uncontrolled. Lifestyle modifications, including dietary changes, weight management, exercise, and stress reduction, are the first-line approach for lowering blood pressure. However, long-term pharmacotherapy is often needed when non-drug methods fail to sufficiently reduce blood pressure and cardiovascular risks. The following discusses 5 common classes of antihypertensive medications: ACE inhibitors, calcium channel blockers, beta blockers, angiotensin receptor blockers, and diuretics. Unmanaged hypertension is estimated to cause over 10 million deaths annually worldwide due to increased risks of coronary artery disease, heart failure, stroke, and chronic kidney disease over time. Even modest blood pressure reductions of 5 to 10 mm per gram have been shown in trials to substantially decrease cardiovascular events and healthcare costs linked to hypertension-related complications. Widely accessible and affordable antihypertensive medications effectively lower risks when other measures are inadequate. As one of the most commonly prescribed first-line agents, lisinopril works by inhibiting angiotensin-converting enzyme, which prevents formation of vasoconstrictor angiotensin II. This lowers blood pressure and protects kidneys long-term. Lisinopril additionally reduces risks of stroke, heart attack, and mortality, as evidenced in large outcome studies. It is generally well tolerated with rare but potentially serious side effects, including angioedema, hyperkalemia, and hypotension, requiring close monitoring. Amlodipine provides effective 24-hour blood pressure control through selective inhibition of calcium ion entry into vascular smooth muscle and cardiac cells, triggering vasodilation. It offers cardiovascular protection comparable to ACE inhibitors and beta blockers, according to trials. Side effects are usually mild and infrequent, although fluid retention and weight gain may occur. Amlodipine interacts minimally with other drugs and foods. Metoprolol lowers blood pressure via selective beta-1 receptor blockade in the heart and kidneys, reducing cardiac workload and output. It demonstrates strong safety and efficacy, lowering risks of recurrent heart attacks, strokes, and mortality in post-myocardial infarction patients. However, metoprolol may occasionally cause fatigue, breathing issues, and mask hypoglycemia in diabetics, requiring alternative agent consideration. Slow titration is needed due to additive effects when combined with other hypotensive medications. Losartan competitively inhibits angiotensin II binding at AT1 receptors, similarly reducing pressure as ACE inhibitors but without risk of cough. It protects against end organ damage long-term, according to trials versus atenolol and hydrochlorothiazide. Losartan is generally well tolerated with minimal sexual dysfunction or cough, but hyperkalemia may occur in renal insufficiency combined with potassium-raising drugs requiring monitoring. As a thiazide diuretic, hydrochlorothiazide lowers blood pressure by inhibiting sodium reabsorption in the kidneys, thereby reducing intravascular volume over time. It effectively lowers pressure both as monotherapy and in combination regimens, according to studies. While hydrochlorothiazide has a favorable side effect profile overall, it may induce new-onset diabetes or hypokalemia when combined with other drugs through electrolyte shifts, warranting replacement supplementation. Common potential complications of antihypertensive therapy include orthostatic hypotension from medications like alpha-beta blockers, long-acting CCBs initially requiring careful dose increases, bradycardia, heart block requiring monitoring with beta blockers in heart disease, hypokalemia or hyperkalemia related to certain drug classes and interactions, edema, sexual dysfunction reported more frequently with specific classes, exacerbation of asthma COPD symptoms occasionally seen with beta agonists, fetal toxicity with most classes necessitating contraception in women of reproductive age. In summary, lifestyle modifications combined with effective antihypertensive pharmacotherapy lowers blood pressure and prevents major cardiovascular events long-term for most hypertensive patients. Careful consideration of individual factors, mechanisms of action, clinical evidence, benefit-risk profiles, and drug interactions optimizes treatment selection and adherence. Continuous research enhances outcomes further through novel agents and new treatment paradigms globally.